Access through the common femoral veins is often required for a number of procedures, both therapeutic and diagnostic. We will discuss mastering access of the common femoral veins in terms of understanding the anatomy and how to properly advance catheters and wires to avoid complications. Our objectives include access of the femoral vein using ultrasound and landmarks to identify the proper location for access, accessing the femoral vein using a 6 French sheath both in a bilateral fashion as well as 2 sheaths in the same access site, and discuss the relative anatomic variance that occurs in the femoral veins. The level of the puncture is incredibly important. If the puncture is too high, it can lead to incompressibility of the femoral vein and could lead to the potential complication of a retroperitoneal hematoma. If the common femoral vein is accessed too low, then an inadvertent arterial puncture may occur, leading to complications such as bleeding or pseudoaneurysm formation. Understanding the anatomical structures for the access of the common femoral vein is important, especially in the setting where anticoagulation and thrombolytic therapy are being used. Knowledge of the common femoral artery location and its lateral approximation to the common femoral vein are important, as well as understanding the location of the inguinal ligament, which can be drawn using an imaginary line from the anterior iliac spine to the pubic tubercle. The femoral vein lies medial to the artery at the level of the inguinal ligament. Below this level, the vein is deep relative to the artery. This allows the operator to understand access of the femoral vein and how best to direct one's needles for proper access while avoiding complications. In our institution, we routinely use ultrasonic guidance for visualization of the common femoral veins and arteries, especially in the setting of anticoagulation, and even more so in the setting where thrombolytic therapy has been or is likely to be used. We anesthetize the skin to avoid shadowing over the common femoral vein and arterial structures, and then look for crossing branches over the common femoral vein, such as pudendal branches of the common femoral artery, so as not to inadvertently stick the artery in these cases. We use fluoro to locate the femoral head and the inguinal ligament in order to avoid the complication of a retroperitoneal bleed. We avoid needle contact with bone and muscle, as this can form periosteal hematomas, especially in the setting of anticoagulation and thrombolytic therapy. It is important to note that for most people, the inguinal crease is not a reliable landmark. However, fluoro is reliable. The inguinal ligament can be drawn from an imaginary line from the anterior superior iliac spine to the pubic tubercle. The puncture should ideally be made in the upper 1/3 of the femoral head to avoid crossing of the femoral artery, as well as to allow for easy compressibility on top of a prominent bony structure following the puncture of the vein. Here we see the ultrasound probe is above the inguinal crease at the level of the inguinal ligament, and the ultrasound image on the right shows the ultrasound finding that the vein lies medial to the artery in that position. Here we can see the ultrasound transducer at the level of the inguinal crease, which is below the level of the inguinal ligament, and we can see from the ultrasound image that the vein lies under the femoral artery. It is important to understand the anatomy in this location in order to properly direct the needle and avoid puncturing the artery. As shown on the picture on the left, we see that the vein lies medial to the artery, which is demarcated with the black line. The puncture site here is noticeably above the inguinal crease. In the picture on the right side, the aim is directed from medial to lateral to avoid contact with the femoral artery, which lies above the femoral vein in this location. Once access into the common femoral vein has been obtained, advancing wires into the iliac vein and into the inferior vena cava should be met with no resistance. If resistance occurs, the use of fluoroscopy may aid in determining the level of resistance or the reason and will help in directing wires. In heavier patients, wires and sheaths can buckle as they are advanced through large amounts of tissue. When wires and sheaths buckle, sheaths can develop burring on the tips, causing traumatic entry into the venous system, which may cause bleeding complications. When larger sheaths are being introduced into the venous system, one must be cautious that the wire has not accidentally traveled into a renal vein or a pelvic vein. To avoid trauma to those veins, make sure the wire motion is free while advancing the sheath. One should also be aware of potential anatomic abnormalities, such as a left inferior vena cava and interrupted IVC. When the wire is in the proper position, a sheath can be advanced and one can begin the procedure. Many procedures require additional access sites, and a second puncture is often required. In our institution, we tend to place our first puncture site a little more inferiorly, leaving the wire in position. Then, using ultrasonic guidance, make a second puncture, usually about 5 to 10 millimeters above the first, and place the second wire into that position. We then insert our sheaths and begin the procedure. This is readily available in most cath labs. It is important to note that we use different access points for separate sheaths because having two sheaths in the same access site often leads to bleeding around the sites and causes hematomas. Another sheath that is available is a dual lumen or a dual port sheath. This is an example in the middle picture of the St. Jude sheath, which has both a 10 French and 12 French access site. Using this sheath allows only one puncture, but it is larger and may cause more trauma due to its size. This dual lumen sheath, however, may not be available in all cath labs. Finally, in the picture on the right, you can see that this particular patient required both bilateral femoral venous access. In conclusion, careful femoral vein access technique avoids bleeding and vascular complications. Knowledge of the anatomy and proper technique can aid in good access technique.